imaging, and those who image, they defend it very strongly. Those who don't, they say that they can see it all on angiogram, and for them the stent boost is more than an imaging tool can offer. So let's see. We'll go through the entire session and see if I can answer this question. So what you see is not always what you get, and it is desire of each one of us to get into the coronary artery, and more so when we see certain images which don't make us feel happy or make us feel secure. We feel that, okay, if we had some tool and we could see, you finished angioplasty and you see some haziness in the vessel, or you see a small thrombus hanging, you feel you needed to do something more, and you needed to, be clear as to what is there. There are certain limitations of angiogram. I spoke about this at length yesterday. So essentially repetition of the same thing. Most importantly, angle dependency, you have to take orthogonal views to see, because there are overlapping vessels. And if you're working purely in the caudal view, if you take iliocaudal, a lot of people like to work for left mains or ostial LADs in iliocaudal. But till the time you come to ariocaudal, you will not get to know the amount of foreshortening you are doing to this vessel. And of course, there is significant inter and intra-observer variability. And the last line which just flashed, it is much more important when you take imaging into consideration. That is, we cannot just assess the vessel wall, plaque composition, extent, and distribution of atherosclerosis. So again, the same, this slide tells you the kind of mistake which you can commit if you rely too much on angiogram. There's always a confusion. Well, intravascular ultrasound was the first imaging modality which was made available, and it's been in use for more than a decade, or close to 2 decades, and it's been used well, but I won't say that the penetration of this modality has been good enough for it to have been accepted as a tool in clinical practice. So it is essentially based on the studies of intravascular ultrasound that optical coherence tomography came into being, and because this was one tool which showed that if you do IVUS guided stenting, you are assured of reduced MACE rates. On the left side is the ADAPT-DES study. This is an all-comers, nearly 8,000 patients. 39% of them underwent IVUS imaging, and those who underwent IVUS, they had reduced rates of MI, stent, thrombosis, and the need for repeat revascularization. Similarly, IVUS XPL was a Zinc prime-based study where long stents were used, and they also noticed a similar thing, that the IVUS guided arm, this was about close to 1,400, 500 patients. So the IVUS guided arm had much better outcomes. The problem with the IVUS has been, rather simple, and I personally have also experienced this because I was using IVUS majorly in the about a decade back. So you really don't know what you're looking at, and that discourages you. And there is so much of guesswork which comes onto the table. But I am talking about the older generation machines. The present newer generation machines are still much better. So you have to really get into it, and there is a significant learning curve. Well, OCT compared to the IVUS is IVUS uses sound waves. So this is an imaging modality which is using near infrared light, and it produces very high resolution images. So it in fact uses light and not the sound waves. And image acquisition is definitely much faster. The images acquired are sharp and are very detailed. So at times it reveals much more than what you can digest. How does one do OCT? For doing OCT, you need a catheter, which is the OCT catheter, which is connected to through a console to the through a dock. So the image on the left side of your screen, lower down, is the imaging catheter with the dock extension, and on the other side is a console. Console has a monitor which faces both the operator as well as the assistant. And it's a rapid exchange catheter, about 135 centimeters in length and 2.7 French width, and it is 014 wire compatible, and it has markers which are present. I'll tell you how and at what distance. So this is the console, which can harbor the dock extension, which is nothing but a drive motor and optical controller. This is what connects the catheter to the CPU, and the images are displayed onto the screen. I feel that whenever I'm there in the institute next time and you are finished with your DM exams and you're around, we have this machine and we have been doing OCT. You will get to familiarize yourself much better with hands-on experience than seeing it here on the screen. So basically, this is a tool which controls the movement of the imaging catheter. So the steps involved are: you prepare the catheter, you remove the catheter from the hoop, you wipe it, and this activates the hydrophilic coating. And now, instead of saline, most of the time we use saline in our practice for most of the catheters. Here we have to use pure contrast. There is a separate syringe which is provided, and through this syringe you have to flush the lumen of the catheter with pure contrast. And you have to keep the syringe attached to it because you will have to periodically do that. We'll see as to what. So the distal port of the catheter shows it's got a blue color tip, two radiopaque markers, which are at a distance of 20 millimeters. And then you'll see a red light coming out. This is a source of infrared light, and 5 millimeters distal to the red light is your lens. It is the lens which acquires the images. So this procedure has to, OCT has to be done using a guiding catheter. So the guiding catheter gets into the vessel, and then you pass on a 014 wire. You give some NTG to cause dilatation of the vessel. Once you've done that, you load the catheter. You can use a 6 or 7 French guide. And in case the lesion is very tight, then you need to dilate the lesion, and using a 2 millimeter balloon, and the pullback length is about 5 centimeters. So the pullback starts, as you can see on the slide, the red color mark is the lens, and from lens backwards the pullback will start and the image will be acquired. So how does it work? It works in a very simple fashion. The light source, which is infrared light, it is constantly emitting, and the camera rotates through 360 degrees and starts moving backwards, and it creates radar style images. So you can see the image, which is like a clock. So generally when we talk about the imaging details, we say, okay, look at 3 o'clock, 6 o'clock, 9 o'clock or 12 o'clock position, thereby telling the person who's looking at these images as to where he or she has to concentrate. Well, I told you at the beginning that you have to use contrast to clear the central lumen. And as you can see, it is this central lumen through which the light source moves. And if this is not clear, or if it is not purged, as you can see in the other image, which is purged, so you will get very poor quality images. So here I will show you if the catheter has not been purged, then you see these artifacts which are coming, you know. So you see radial artifacts which are moving all around because the catheter has not been purged. In addition, you also need to ensure that the vessel, as the contrast flow in the vessel is correct by giving a gentle puff. And if you don't do that, so the basic premise is that we want all the blood column, the vessel, to be free of the blood column, because if there will be blood, the blood will not permit the light source to image the vessel wall, and you will get swirls. So as you can see on the left image, there are a lot of swirls. These are the RBCs, or the blood particles, which are there floating inside the vessel. And on the other side, you can see a nice clear-cut image And what you see is a small linear mark at around 5 o'clock position is the guide wire. This is the 014 guide wire, and it produces a shadow which is there at 5 o'clock position. Well, when you've acquired a nice looking image, what you can see in this image is you'll be able to see all the three layers as are shown in this slide. You can see the intima, you can see the media and the adventitia. All three layers are absolutely clearly seen, and it gives you a very nice magnified image. So you feel really thrilled. Well, most of the time we flush the lumen with a syringe, but you can also use power injectors. If you use an injector pump, then you, in all situations, you use 100% contrast. So you have to inject at 4 ml per second for 3.5 seconds, giving actually around 14 ml of contrast at 300 psi. So most important and the fundamental requirement in OCT is you have to clear the blood column in the vessel, and this can be done using pure contrast. There are studies available where they've used saline dextran, but I have tried using, I haven't used dextran, but I've tried using saline, but the image quality is very poor. So it becomes very difficult. So there are something called 4 P's in OCT. So first P stands for positioning the catheter. You have to cross the target lesion and position the catheter. The second P is for the purge. You have to purge the catheter lumen. As I showed you, if you don't purge the central lumen, you will have problems. The image artifacts will come. And third is a puff which you give through the guiding catheter to see if the guide is coaxial, properly hooked. And so that when you will inject contrast, this contrast will flow into the vessel and clear the vessel wall. And the last is the pullback. Well, invariably this question is asked as to how does it compare with IVUS, because it is essentially because of IVUS this came into being, this modality came into being. And while at the beginning of this session, Madam asked me as to how does it compare with the IVUS. So, okay. Now, if you see the axial resolution of OCT, it's about 15 to 20 microns. So it's about, 10 times higher axial resolution OCT possesses compared to IVUS. The pullback speed of OCT is 20 millimeters per second. Now, what happens with IVUS is that in IVUS, you have both the mechanical and automatic pullback options available. But in both, the maximum speed you can go to is about 1 millimeter per second. In manual, you have to pull it with your hands, and if you do a little faster, your image quality goes. Here, it pulls back, it comes back at the speed of 20 millimeters. So it's about 20 times higher speed. The scan diameter, since it's a light-based modality, the scan diameter is smaller compared to IVUS, and the tissue penetration is much, much lower of OCT. So which indirectly tells us that if I have to look at tissues which are deep within the vessel wall, OCT is not the right modality. So if someone is talking to me and saying that he or she wants to know as to what is the configuration of plaque in the left main, OCT is absolutely not the right modality because the tissue penetration is so small that you will not be able to see any plaque composition in the vessel wall. The lateral sampling is again, so when it comes to surface details, the axial, lateral magnification is tremendous. But if you go in for the tissue penetration or the depth analysis, the OCT does not work at all. And most importantly, as I already said, you need to clear the blood. The blood has to be cleared. So what in effect I've told you is that OCT has got much superior resolution, which is about 10 times better than IVUS. It acquires the images very fast, so it's about 20 times faster than the IVUS. And it basically offers 40 times faster image acquisition to IVUS, and it takes just about 3 seconds, less than 3 seconds to do that. It's fairly accurate, and it gives you more accurate measurements of the vessel wall compared to IVUS. We'll see all that as the talk progresses. And as I told you, the surface details are very well seen. So if I have to look for malapposition, stent edge dissection, thrombus, or tissue protrusion, this is the modality, because IVUS is not going to show things better. The same fact which came out of iLumen study, it clearly showed that this was a study which was where IVUS and OCT both were compared, and it clearly showed that there are approximately 2.5 times major dissections which are picked up by OCT, and there were 45% more major malapposition and 3 times more major plaque and thrombus protrusions which are detected than that which was detected by IVUS. So I mean, the surface details and other things are picked up much, much better by OCT than by IVUS. So when does one do OCT? You know, when you have to do imaging, which is IVUS or OCT, you do it at 3 different times. You do it pre-intervention, during stent deployment, and post-stent deployment to pick up the complications. So let us look at the pre-intervention assessment, which essentially involves assessing the plaque composition, identifying the reference segments, and choosing the right stent. So this is an OCT pullback, and we've given the L mode picture. That means it's a longitudinal mode picture, wherein while you do the pullback, you look at the lesion morphology and its extent. You, by virtue of measuring the area stenosis, you get to know the severity of the lesion, and you can also know the length of the lesion. And it also gives you, most importantly, the reference diameter. That means, as we all know, when we select the stent diameter for a given vessel, we go by the distal reference diameter. So here we can clearly see, as marked on the slide, the lesion length is 26 millimeters. And we've also measured the diameters. The distal is 3.2, proximal is 3.24, and we need to round off. So it gives you absolutely what you need to measure. We'll see a couple of more cases in detail where measurements were performed. So the next part is looking at the plaque composition. So we know that there are different types of plaques. If you have a lipid plaque, these are the plaques which are full of lipid material. And as you know, the lipid material will not allow the light to go through. So these attenuate the light source. So when the light is put through a lipid plaque, it gets attenuated. So it has very low tissue penetration. So these are the plaques which will be very bright on the surface, but they will absolutely not show anything beyond the surface details. So they have a diffuse shadowy edges, and light will not go through. Now, if you compare to them, the fibrous plaque has got very high backscatter. It is homogeneous. As you can see, there's all around the plaque appears to be really bright and is reflecting lights, and there is hardly any attenuation of the light. Now, compared to these two, the calcified plaque, it's kind of heterogeneous. You see, it has got very, very sharp edges. So it is heterogeneous with extremely sharp edges. If you see on the right lower part of the slide, you can easily see all well-defined margins, and the light can go through these sharp margins and will show you the tissues beyond these sharp margins. So there is deeper tissues can be easily visualized. You also pick up vessel wall damage, as is seen on the slide, where you can see a plaque rupture, and the double asterisk is where the false lumen is, and the guiding and the imaging catheter is in the central lumen. You also pick up red thrombus. So red thrombus has got high backscatter, white arrow. That means on the surface of it, the light will get reflected, but there beyond, the light will get absolutely attenuated by the mass which is lying behind that. Vis-a-vis this, the white thrombus, the light is able to go all around, and you will have it appearing like a white thing, and there will be no attenuation of the light. So whatever I have said is summarized on this slide. So when we look at the lesion could be either bright or it could be dark. A bright or a darker looking lesion with very low attenuation. That means if you put a light source and it does not attenuate and it has got sharp edges, then it is calcium. Whereas a darker looking lesion, which has got very high attenuation and diffuse edges, then it is lipid. Whereas extremely bright looking plaque with extremely low attenuation is a fibrous plaque. Well, you have to get to start seeing these when you start performing, and they will certainly, one or two cases, and you'll immediately get oriented as to what is happening. Now, the other way of assessing the lesion is, looking from the point of view of where the abnormality lies. Let us see as to where the abnormality lies. So in a normal vessel, we should be able to see the intima, media, and adventitia. All the three layers should be seen. So if that is the case, then we say that, okay, it's a normal vessel. We don't need to do anything at all. If there is an abnormality, let us find out as to where the abnormality is located, whether it's located in the lumen or it's located in the vessel wall. So the example of lumen is, if there is very high attenuation, then it is red thrombus. And if there is low attenuation, it is white thrombus. So I'm looking at abnormalities in the lumen. So high attenuation, red thrombus, low attenuation is white thrombus. If there is a problem in the vessel wall and there is diffuse shadowy edges with high attenuation, it is lipid plaque. Whereas if there is low attenuation, that means the light is able to go through that plaque and I can see things beyond, then it is calcium. So calcium has got heterogeneous composition, sharp edges, and the light source can go through it. At times there is a mix. You see a vessel wall which is fibrous, or it can be fibrofatty. That means it has got an element of fibrous tissue on top and there is lipids behind. But it can be calcific. Can you see this plaque? So nicely it is seen. This is one image which I think none of you will forget. Such nice sharp edges. Red thrombus, white thrombus, and tissue protrusion. These are abnormalities within the lumen. Now let us see a couple of case examples. So this talk essentially will have a lot of case examples which will, keep the talk lively. So let us look at the ACS subset. We know that acute coronary syndrome essentially and majorly is caused by disrupted fibrous plaque. And this disruption could be by a ruptured plaque, or it could be because of a calcific nodule. In the vicinity of the calcific nodule, the membrane gives away and you have formation of thrombus. And the ACS can be because of intact fibrous cap when you have plaque erosions. That means the endothelium appears essentially normal and there is formation of red thrombus and a slight break, which we know that the ruptured plaque is seen as about 65 to 67%. And plaque erosion is there in about 20-25%, and 5% can have a calcific nodule, and remaining 5% can have miscellaneous causes which include tight stenosis, dissection, intramural hematomas, and fissures. Well, this was a case of RCA ectasia. If you see the distal RCA, and the person had presented with ACS, and we could see there is a filling defect. And I'm reasonably sure any one of you also would have picked up and there would have been a kind of debate as to what is happening here. So this was the OCT image. The OCT image showed that there was again a disrupted plaque. And the vessel was dilated here. And what you see is a red thrombus. This is the red thrombus which is filling the vessel. So what we had was a ruptured plaque and there was red thrombus within this ruptured plaque. Well, two patients with anterior wall MI, similar looking lesions. One was done in Bangalore, the other I was doing a live workshop in Mangalore. So the lesion is at the exactly similar looking location, which is, mid-distal LAD. And we did OCT for both the cases. And OCT showed, in case one, a disrupted plaque. And it also showed a disrupted plaque in the case 2. How are these two plaques different? So the case 1 was a fibrocalcific plaque. So this is the calcium. If you can see my arrow, it points to the calcium. So this was a fibrocalcific plaque, whereas this was a soft plaque. You know, this was a soft plaque. That means this was a lipid-laden plaque, and the other was a fibrocalcific plaque. So I mean, for the same kind of manifestation, you can have different configuration of plaques which you pick up. Angiogram, as you know, could miss about 38 to 40% of calcium, but the OCT has got a very high sensitivity and specificity. A young male, very common, plaque erosions are common in smokers. So you can see proximal LAD, which is extremely thrombus laden. So it is full of thrombus. So I have a very strong, I shouldn't say this. I don't like stents so much because I feel they add to misery more than anything else. So they should be used where you're, justified in using them. So this patient, you should look at the vessel wall. So can you see a cloud buildup? This is the right thrombus, which is there. But look at the remaining vessel wall. There is not even aorta of, plaque in this vessel wall. It is absolutely intact. It is just thrombus laden. There was a small plaque which maybe there would have been fissuring and the plaque ruptured, and the proximal LAD shows plaque erosion. So normally in these patients, what we do is that we put them on triple therapy. We put them on dual antiplatelets with anticoagulation for a period of 2 to 3 weeks. And when you get them back, the vessel is absolutely pristine and normally flowing, and generally seen in younger individuals who have majorly smoking as one of the risk factors, but I haven't seen anyone with any other major risk factors. So small plaque erosion, and that leads to formation of thrombus. Well, this is yet another case which had interesting findings. Anterior wall MI, the patient had undergone stenting, and you see the proximal parts of the vessel being interrogated. Look at the lower part of the film where my arrow goes. The left main has got a plaque. And this is the guiding catheter. I will show you the small cut images. So left main was absolutely plaque ridden, and there were different types of healed plaques and other plaques which were present. And the image showed, as you can see here, thin cap fibroatheroma as well as healed plaque. So this was a thin cap fibroatheroma. I will show you more images of this. And these are the healed plaques or the lipid-laden plaques. So let us look at a couple of case examples of calcific plaques. PCI2 LAD being performed, the lesion dilated, the diagonal was was wired, and we thought we'll put in a single stent. There was calcium mark. These are the calcified lesion, calcium mark of greater than 180 degrees, which was broken on dilatation. So you have broken calcific ring. And following that, the stent was implanted. Angiographic result was very nice, but you look at the OCT image, it shows malapposition. Nothing much could be done because these lesions, if you dilate very strongly, they will cause strut fracture. So it very clearly tells you whether you made your bed well or not. So you have to do high pressure dilatations. So calcium in the vessel wall could be deep, it could be nodular, or it could be superficial. Deep calcium, we are not bothered. We don't need to do much about it. We need to just dilate the vessel. We can use different balloons, MC scoring or cutting balloons. Nodular calcium is a totally different ball game, and it becomes very difficult to assess. But superficial calcium, you have atherectomy techniques which work, which could be rotablation calcium or other things, and you can use any one of them with this. So this is a case example of a nodular calcium. This is angiocore registration. That means when you do the angiogram, the cursor, as you can see on the angiogram, is moving backwards, and as it moves backward, you can see the images being acquired. So there was thick nodular calcium in the mid RCA, the white filling defect, which you can see now. The entire vessel is calcified. So this is how a thick nodular calcium looks in the vessel wall. You can see there were multiple such nodules. Now these nodules are absolutely not amenable to rotablation. So a lot of people mention that I had a nodular calcium and I use a rotablator. No, absolutely not. Rotablator will not work, and you need either EVL or you need to send these patients for surgery. So these calcium will not go up with any atherectomy technique. Whereas superficial calcium, this was one LAD disease in the osteal LAD. It showed there was a little bit of calcium. So we prepared this patient for rotablation. We thought, let us do imaging, and on imaging we realized that the calcium is very thin. So you see calcium, superficial calcium at 3 o'clock position, it was very thin. By thin, I mean a calcific plaque which is less than 500 microns is amenable to ablative technique. So this calcium with the cutting balloon was ablated and the vessel was stented. So based on OCT, we have something called a CVI score, which is a calcium volume index, wherein you look at the maximum calcium angle and you score it. You look at maximum calcium thickness and you score it, and the calcium length. So basically total score which is given in CVI is 4. The higher the score, the more are the chances of the patient having severe calcific disease. So that means an arc of calcium greater than 180 degrees with thickness more than 500 microns and length more than 5 millimeter will get a score of 4. That means this calcium is very severe and not amenable to, will certainly not amenable to routine angioplasty tools and will require something more. So one case example of such calcium, a typical case of napkin ring calcium, you can see it's circumferential. You see the calcium here? It is extremely calcified vessel with, you know, a complete ring of calcium as if it is napkin ring. You see, all around calcium is present. So there is so much calcium, and when you treat this calcium, all you do is that I did rotablation for him because there was no option because he refused surgery. When you rotablate, you damage first the overlying endothelium, you produce dissection. Immediately the platelets will come to damage endothelium and you will have white thrombus forming. But the ablative ring is as small as shown on the slide. So ablation will just produce a small crack in the calcium, which is now to be broken using NC balloons. So we did that, and you see dissection and the broken calcium ring. So complete plates of calcium have been broken, and you create white thrombus, and you now are ready to have a bed, which will kind of make your stent fit properly. So now that we've seen the different plaque composition, we've have to now confirm the landing zones, and we have to see that we've measured the sizes well. And by landing zone, I mean is that your stent should neither land on a soft plaque or on a fibrocalcific plaque, otherwise you'll produce dissection. So as you can see in the given case, we have done the OCT, and what we've noticed that in the left main segment, there was a thick plaque which was present. And so the landing zone has to be much different from that which we initially thought. Case of left main trifurcation, distal left main stenosis which is trifurcating, and the best estimate of the sizes of these vessels on the table between me and my colleague was that we thought L6 is 3 millimeters, LAD is about 3.5, and left main we could go up to 4.5 with ramus coming out 2.75. We did OCT for this patient, and we did a pullback from the LAD to the left main. Again, mixed fibrocalcific lesion, and we did with the intent of sizing the vessel, and there was significant stenosis. There was a lot of left main involvement. What I want you to see now is as I'm coming into the left main, you see you can't see nothing beyond the circumference because the tissue is not seen beyond that because the vessel is so big that you can't make out anything beyond the superficial layer. So now we measured the LAD. LAD was 4.5. We measured the left main. Left main was 5. We similarly did the pullback from the circumflex. Just to save time, I'll show you. Circumflex had a lot of calcium, which was there. and the circumflex diameter was 3.5, and there was significant stenosis of the left circumflex ostium. So we were grossly undersizing. So in this regard, I will tell you about Opus class study. This was the study which compared the sizing of vessel based on angiogram, OCT, and IVUS. And the IVUS measured the using the phantom model. It used only the central lumen. And what was noticed was that the actual phantom and the OCT sizes completely matched, whereas OCT was, IVUS was oversizing by nearly 8%. So the measurements as taken by OCT matched. ILumen 3 recommends that when you're sizing a vessel, you should look at the external elastic lamina. When you look at the external elastic lamina for more than 180 degrees, this is the area of the vessel which is absolutely not plaqued. So you're supposed to measure the diameter at this segment. If this is not seen, then the lumen, as you can see on the right side of the image on the slide, the lumen is used, whereas EL is used when you can see it. So at times, if the vessel is too big, you will not be able to make out EL. At times, the vessel has got a lipid plaque, you will not be able to make out EL. In the absence of you not being able to locate the external elastic lamina, you should use the lumen and size the vessel. So what have we learned? What we have learned is that the OCT does the most accurate sizing, and you compare it to the phantom models. IVUS does oversize, as I told you, the oversizing is to the tune of 8%. If you use QCA, you will be undersizing. So, and yes, of course, there is considerable intra observer variability, and that is why a lot of colleagues call for help and they say, can you size, and what do you think is the size? So that is how it goes, by the gut feeling and the experience. But OCT gives you absolutely the right size which the vessel is. So once you size, you will select the stent as per the lesion configuration. In this example, if I use the lumen, I will size it to 2.5. But if I use the external elastic lamina, I will use 2.75. The other case, as you can see in D, the diameter, if I use the lumen, is 3, whereas if I use external elastic lamina, it will be 3.25. So the distally, the vessel is 2.75, and proximal vessel is nearly 3.25. Well, in the immediate post-stenting period, you are supposed to look for all of these findings, whether your stent is expanded well or is underexpanded, whether you created a dissection, you've had a geographical miss. That geographical miss implies that you've not been able to land at the normal segment. You've got some malapposition, you have some tissue prolapse, or you have created a kind of hematoma. So these are things that you have to look for. Now, geographical miss is a thing which is going to trouble you. That means that if you've had a geographical miss, the patient certainly will come back. Now, it can occur in the longitudinal axis, that means at the edges of the stent, or it can be axial, which is in the center. So the axial geographical miss is absolutely, you will never ever be able to pick up on angiogram. Whereas longitudinal geographical miss, you can pick up because if you cause the edge dissections, you can pick up that, or you will also be able to see a step up or a step down at the end of the stent. If you created a geographical miss, as is shown by this study, which was done in 2008, the event rate is much higher, or the target revascularization rate is much higher in those who've got geographical miss. So how does one identify the healthy segment? You have to use OCT again. And a normal appearing cross section is the one where the lipid arc is less than 180 degrees. That means at least you will be able to see 180 degrees of tri-layered structure. The plaque, if present, has to be less than 50%, and there should be absence of any fibrocalcific lesions. So these are three important things which have to be present in the vessel wall. case example, CTO-LAD and RCA disease. So we finished the CTO-LAD, we opened the vessel and were pretty happy. And then 5 days later, brought this patient for RCA angioplasty. RCA angioplasty done. We just thought we'll check on CTO-LAD, which was an ostial stenosis. Can you see a filling defect in the proximal part of the LAD stent? Yes, there was a thrombus which was sitting there. So we did an OCT, and as the OCT images you can see, okay, as it comes closer, we have had considerable under expansion of stent along with the thrombus there. So you see malapposition, you see red thrombus being present, and we've dissected. So when we implanted a stent, we were pretty thrilled that we've opened a CTO, flush CTO segment, and we've done a beautiful job. But what we've done in addition is that we've dissected the left main, and this dissected left main led to formation of thrombus in the proximal part. So we were left with no choice. We had to stent from left main to LAD. And this is what a geographical miss can do. So post dilatation of the ostial stent led to rupture of the left main segment, which when we brought the patient back for RCA angioplasty manifests itself by formation of a small thrombus. Had the thrombus not come up, we would have missed, and this patient would have certainly come back with anterior wall MI or maybe in cardiogenic shock because the entire left main might have got occluded. We finished it with an OCT, and that showed complete apposition. If you can see all the axial cuts here, they show complete apposition of stent to the vessel wall. Well, certain other things which you can look for is, as I told you, stent expansion, coverage of the lesion, where the stents are uniform, there should be no protrusion or edge dissections. So stent expansion has been found to be very, very important parameter. And what is given in the guidelines is that your stent should have cross-sectional area more than 80% of the average of the proximal and distal reference, or more than 90% of the distal reference. Why it's 90% of the distal reference is because this, can you just hold on? There is some disturbance. I'll just close my window. So as the vessel tapers distally, if you use the distal reference segment, then it has to be more than 90%. And but it's good enough to remember that the minimum stent area should be more than 80%. You see an underexpanded stent. So this is a stent rendered image. Stent rendered image, you have a imaging section in the OCT where you can remove everything. So what you see is the stent and the guide wire, correct? So there is considerable underexpansion of this stent in the mid segment. And the same was post-dilated. If you can see the distal proximal LAD and the LMCA. So all the stents have been very well expanded and they are fine. RCA stent, which again, if you see the left panel, there is a considerably underexpanded stent. And post-optimization, the stent is uniformly expanded. I haven't shown you the angiographic images of these, and you can't make out, especially when you're using overlapping stents, especially after the plasty of chronically occluded vessels, you can't make out whether you left underexpanded stents there or not. So yet another case example where the stent has been expanded uniformly. If the certain quadrants of the stents are not expanded and the others are well expanded, we call it malapposition or incomplete stent apposition. Now, malapposition can occur at the time of the implant, or it can come up later, So the stent malacquisition can be acute, or it can come up a little late. Acute is invariably if there is a calcified plaque or a thrombus which is present, which does not permit the stent to expand. And the late acquired malapposition is because of the resorption. During follow-up, the thrombus has resorbed. You've done ACS, you feel that the vessel diameter is around 3.5. You put a 3.5, the thrombus gets resolved and the vessel is 4 millimeter. You develop incomplete stent apposition, which is probably because of resolution of the thrombus or the necrotic material which had come out, it goes, or in certain amount of cases, it can be because of positive remodeling of the vessel, as you see in the lower image here. So any struck to vessel distance of more than 400 micron extending for greater than 1 millimeter is called malapposition. Now this is a fly-through view, which is again possible. So my cursor is flying through the central lumen, and it shows you these are the stent struts which you are seeing. They are well attached to the vessel wall, and it's the coronary O14 wire which you see like a rope which is there within. So these are the this is the quality of image which you can generate. In the lower longitudinal panel, what appears in red is the malopposed segment. So this is the malopposed segment. The malopposed segment will appear always red, and it will show as red here. So this is the part which appears red. You can see at the beginning. So this red thing where I've stopped is the malopposed segment. So correct. And this stent was expanded, and post expansion, everything has become white now. So that means it is a malopposed stent post expansion. Now, at times we don't get to know, and we leave these stents which are malopposed, couple of struts hanging here and there, and they start healing, and they heal by the endothelium growing on top, and they give you a kind of bumpy appearance. Can you see this bumpy appearance of the struts? The endothelium has climbed over, and this was one area between, say, 8 o'clock to 11 o'clock, or maybe 12 o'clock, and this segment who had malapposition. The other side, the stent is not very well visualized, but this gives an appearance of this thing. So ILUMIN 1 study pointed out that pre-PCI impacted the planning in about 57% of cases. So if you've done images in patients before deciding as to what is the size and length, so they noticed that in 57% of patients, the decisions were revised, and in 43% longer and 25% shorter stents were selected. And the stent diameter was larger in 8% and smaller in 31% of patients. So nearly 57% of patients had a change of strategy. And this led to a very good outcome. What they noticed is that in the OCT guided PCI, there was significant reduction of 1-year rates of myocardial infarction. And this was predominantly driven by 32% malapposition, 32% edge dissection, and 27% under expansion. So they could manage all this, and this is what translated into very good results. And the other arm, the operators are pretty happy, saying that we produced very good, angiographic results. It was in ILUMIN 2 that similar effects were noticed, and that the OCT and IVUS kind of were found to be equivalent in terms of the minimal stent area. So these are the studies which I have interjected here, and today I have not decided to go into details because it will be slightly too much for you. I have kept it at basics. So I mean OCT is equivalent to IVUS in terms of picking up the stent under expansion and dealing with it, because IVUS studies are available, and they've clearly demonstrated that if you use IVUS for doing PCI, you produce good long-term results. Left main stenosis, which was kind of, I call it like, it's like ecclesia cardia. So you have ostial stenosis, which was with considerable dilatation of the left main. So I had to put a 7 millimeter renal stent in this, because nothing else also could fit in. So a bare metal stent, and the lady came for follow-up because this was isolated left main stenosis. She refused surgery. Sorry, I mean there's something which is going wrong. Yep. So there was on follow-up hardly any reflux from the guiding catheter. So I knew that there is some amount of stenosis. Now we did the OCT for this aneurysmal lady. This was a stent which is hanging, and it has got a lot of thrombotic material attached. So you see this, the MLA was 28.9. No amount of, mm, I mean, no stent could have matched the MLA, and the MSA was 8.9. So this lady, however, still refused surgery. We had to just put her on dual antiplatelet and wish her well, see well. At times you pick up edge dissection, the white arrow which shows these are seen post-stent implantation, and these are produced because of vessel overstretching, and or it could be because in a vessel which has got fibrocalcific plaque or thin cap fibroatheroma or an eccentric plaque which gives way. So what is a significant dissection? A significant dissection is one which involves greater than 60% of the vessel circumference, and it extends for about 3 millimeters in length and causes residual lumen to become less than 90%. And it also extends to the deeper layers of media. So that is what is a significant dissection. So otherwise, what I tell most of people is that a significant dissection is one which produces angiographic flow compromise, and the reference vessel disease with a small luminal area is going to be a problem. So you need to treat. So any angiographic flow compromise, small luminal area, and a large floating flap needs to be treated. We also pick up tissue prolapse or plaque prolapse as is seen in the image, and one of the rare images where in the stented segment we picked up a dissected flap, and the tissue prolapse is most, it's kind of protrusion which is more than 50 micron in diameter, and it is invariably picked up by OCT and cannot be seen. You see the IVUS sensitivity, which is, it picks up only in 33% compared to 98% in OCT. It can be a smooth, disrupted fibrous type or irregular type. Invariably in ACS situation, you pick up the thrombus which comes as protrusion within the stents. It's only the lipid plaques which carry a very high incidence of restenosis. The other plaques are pretty safe. It is generally seen when you have a larger thin cap fibroatheroma, the one which is seen on this slide. You see this very thin layer, thin cap fibroatheroma, which is classically defined as the cap thickness of less than 65 micron. It's also seen when you deploy a stent in a ruptured plaque, or you aggressively dilated small vessels, or if there is a positive remodeling. RCA is a vessel which has more of these because there is less tapering and fewer side branches, and it is invariably seen with open stent design stents, and less with the closed cell design. Certain late complications include neoatherosclerosis in a BMS stent, a neoatherosclerosis in a drug-eluting stent. As you can see, the neoatherosclerosis in BMS occurs in a milieu of very thickened plaque, whereas the plaque thickness is more heterogeneous with the DES, because the segments where the stent is well opposed will have very thin layer of atheroma growing, or the thin layer of neointimal hyperplasia happening, whereas in others it will be more. A very late stent thrombosis, RCA was blocked, and we took OCT runs, and you see what you see is considerable neointimal hyperplasia with neoatherosclerotic plaque. There was a plaque rupture and thrombus formation. So intimal hyperplasia, a ruptured plaque, which is present at around between 9 and 7 o'clock position, and a red thrombus which has formed. So everything is explained. ISR appears like this. You see the stented segment, double layer of stent, and you see thickened hyperplastic layer. And invariably, these segments are dilated with the balloon. So this was the first inflation. You can see the cuts at 12 o'clock and maybe 8 o'clock position. As you keep dilating, multiple dilatations are done, the cuts start becoming shallower and the thickness starts coming down. And when you do the final inflation, the lumen increases, the thickness of the vessel plaque keeps reducing, and the cuts are no longer seen. Same is the case with the scoring balloons. Scoring balloon produces an elliptical cut, as you can see here. It's an elliptical cut, and you see the luminal gain, and these elliptical cuts start widening and they start becoming bigger and bigger at the time of final inflation. Couple of cases of left main bifurcation. As you know, the Achilles heel of left main is the side branch. So there are two novel predictors. One is the cranial tip angle, and the other is called the branch point cranial tip distance. So I don't think you need to remember this. But what is important is that if the cranial tip angle is narrow, if it is less than 50 degrees, you have chances of side branch compromise. If your BPCT length is less than 1.75 millimeters, you have chance of side branch compromise. So this is a case where you had very short cranial tip angle, and there is a calcified plaque on the opposite side. So when you put a stent, the carina will get displaced and the side branch will close. So you have certain OCT predictors which will tell you that if the cranial tip angle is less than 50 degrees, the carina will shift and the side branch will close despite whatever you can do. And if there is a calcified plaque located at the opposite end, the vessel or the stent will expand towards the side branch. So it will certainly cause shift of the carina. If there is a plaque burden at the side branch ostium and the plaque burden is more on the opposite side, then it certainly will affect it will certainly migrate into the side branch. So in side branches, the atheromatous plaque burden, if it's more than 56%, or the MLA of the side branch is less than 3.7 millimeters, there are very bright chances that you will lose this side branch. So case example, the cranial tip angle is very narrow. You see the angiographic images on top. The LED was dilated, and once the LED was dilated, the diagonal disappeared. Now the cranial tip angle was a little broader. It was around 60 degrees or so. A vessel was dilated. Again, the LED dilated and the diagonal continues to flow. This is a case example. There was a calcified plaque opposite the side branch. Post dilatation, see the side branch ostium. It has almost got chinked because the stent expanded towards the side branch, thereby compromising the side branch in the post-implant image. Well, a very tight distal left main as well as LAD diagonal disease. I'll show you again. Okay, I need to go back and come back. So very severe disease of distal LAD and diagonal, both. Okay, this is not playing. So we did DK crush for both LAD D1 as well as left main, LAD LCX. So what OCT helps us is it helps us see as to where our wires are crossing. If you do DK crush, you need to go through the proximal strut. Two wires in the central lumen. White arrow is what is moving. It has gone through the proximal strut into the vessel. So this is how OCT helps you. You can easily make out as to which strut have you gone through to do this vessel. Post stenting, you also get to know whether the side branches have been dilated or not. This was pre-side branch dilatation. This is post-side branch dilatation. You can see, I will show you a couple of still images. You will be able to make out much better. Sorry. So this is when you, in the upper image is again a stent rendered view. So you see the tissue stent and the ostia of the side branches. These are kind of marked by, they appear pink. So the white arrows appear. So this is the side branch, which has got a lot of metal struts across, you know. So once we do dilatation, now you see the struts have gone, and this appears absolutely free of struts against the diagonal branch. So we rotate and we see in different angles. So this is a stent rendered view. This is pre-side branch dilatation. As you can see here, the in the pink looking ostia, there are a lot of struts which are there. And once you've done the dilatation, they appear absolutely, see the pink circles, they are absolutely free of metal struts, and they appear absolutely fine and clear. So pre balloon dilatation. So final kissing balloon dilatation removes the struts. You also create a neocarina. This was the LED D1 and this was the LED LCX bifurcation. So you see the carina which is formed well and all the stent struts are there. When you do provisional stenting, you look at the wire which is going to come from 3 o'clock into the stent, and we are moving from distal to proximal. So we want a distal cross, and the wire is crossing. Wire is already crossed while we are coming now to the proximal part. So wire is already into the lumen before you reach the proximal part. So here you see a distal cross. In the provisional stenting, the wire is held up in place by a strut, and it is distal. The guiding catheter in the proximal part, the left image. And post dilatation, the wire has fallen back. There are two wires, one going into the circumflex ostium and the other which is going into the LAD. So it clearly shows you that you've gone through the distal strut and you're left with absolutely no struts across the ostium. One of the tap stentings which were done for an ostial tight circumflex disease, and when we did a pullback, a newly implanted stent, what we could make out was the ostium was very nicely made. And what you will see in the other images, this is the ostium, which is absolutely free of any metal struts. You rotate and it appears absolutely bang on and fine. And you do a pullback from the LAD segment, which is already endothelized stent. So this was a lady who had a stent from left main to LAD and developed circumflex stenosis. Endothelized stent will not appear as bright or normal as the previous image was showing. So here you can see the stent struts are very nice and bright. So large LED ostium, and since it was tap, in tap, one end of the stent is crushed, the other end is hanging. So all you need to know is that it produces, so this was the case which I had shown you, a trifurcation lesion. We put 3 stents, we did a DK crush. So this was native fly-through view while we were assessing size and we were calculating the BPCT and the carinal tip angles. This is a little more complicated case, so I will run through it fast. You don't need to know. So we did a DK crush, stented the LAD. This was the first case. LAD was stented. We did a port and second case, and we completed the LAD D1 crush, and the angle was pretty wide. We opened now the distal left main. The basic idea was to finish it with a reverse crush because the angle was not suitable for tap. We tried doing tap, but we created a big neocarina there, this thing. So we did a reverse crush with kissing balloon between ramus and LAD, and ramus and LCX was done. A triple kissing followed by a report of the left main. LAD distal had disease. The FFR was 0.83. Sorry, this was an RFR, I think, RFR 0.83. So this segment pre-post, this was also stented. Okay. And the distal LAD was also stented. This was pre and this was post. So the ramus ostium with metal, and you can see 3 guide wires in the ostium. So there was a lot of metal in the neocarina. I don't know how this patient will ultimately do. We still wanted him to undergo a bypass surgery, which would have produced much better results. So this is a fly-through view of in the stents. The one wire is going into the ramus, and what you can see is as it goes to ramus, on the lower 2 panels are the circumflex and LAD. They are free of any struts. Well, there are certain limitations of OCT. The important ones being that I told you that the penetration is very low compared to IVUS, which is almost 10 times higher penetration, and the you cannot assess the plaque volume, or you cannot visualize plaques in large vessels. So if someone tells me you have to do a left main and you have to visualize and you have to find out what the plaque burden is, what the area is, OCT is not the modality. It will not tell me anything. And there is considerable attenuation of the image with lipidic plaques or with red thrombus. So one cannot really make out as to where what is happening. Osteal lesions, they're a major compromise because you need blood clearing and you cannot do blood clearing. So osteal LED and osteal left main and osteal RCA, you just cannot use OCT. And since contrast is the media which is used for producing good images, it becomes very challenging in patients with renal and LV dysfunction to perform OCT. So I come back to the same question which I had posed in the beginning. So why do imaging guided PCI? Well, there is more than enough clinical data now available which says that if you do an imaging guided PCI, you produce superior results. IVUS and OCT complement each other. You know, it's not that they are competitors, but yes, IVUS has a little larger learning curve. IVUS is fantastic for osteal lesion. IVUS is fantastic for plaque burden assessment. IVUS is probably a modality to be used in patients with LV dysfunction and those who have renal dysfunction. But yes, IVUS has a learning curve. If I do 2 or 3 OCTs, I become master. But IVUS requires a little longer training. The resolution of the surface details with IVUS are very difficult. That is to make out whether there is intramural hematoma, to make out whether there is plaque prolapse, whether there is significant dissection. So it makes it slightly difficult. OCT is much more sensitive, and IVUS uses media to media sizing. So because of which the iLumen 3 criteria came into being, and they said you do external elastic lamina sizing. So it has been seen in studies. I will quote a few studies before I end my talk, that the new findings led to, kind of additional interventions in 34.7% of patients. So if when the OCT was used, it was found to be much more sensitive, and there were additional interventions in nearly 35% of patients. And the decisions majorly, if you see, in almost 80% of the vessels, the decisions were transformed pre-intervention, and 55% the decisions were transformed post-intervention. So this is a landmark trial, iLumen 3, which studied around 450 patients. And OCT changed the decisions as is shown on the slide. So increased stent expansion was required in 5.6%. Increased detection of major malapposition was noted in 65%. And dissections were picked up in 26% of these patients. So important things to remember with OCT are that it uses the reflected light to image the coronary arteries. It images very fast, and the images are very clear, and they are detailed and extremely easy to interpret. 2-3 cases you do, you will not need any help or guidance. So it certainly optimizes and it translates into very good results. This is one of the recently published registry data from London, where most of the hospitals are using OCTs, which was essentially from 9 large PCI centers. And they clearly demonstrated at 5-year follow-up that OCT guided results were absolutely significant in terms of good outcomes. There was significantly less all-cause mortality compared to angiographic guided arm. So this still is a registry data, and the results were, shared better than IVUS guidance even, but that did not reach any statistical significance. So what I want to convey is that we are gradually getting to see more and more studies which will kind of tell us that it's a good modality to use. We've had till 2015 these trials published. There haven't been any major trials. iLumen 4 is about to come, and so is the October. And these are trials which are looking at, PCI optimized bifurcation stenting is what October is looking at. And Illumin 4 is more for PCI outcomes. So these are trials which are in the pipeline and they will further consolidate. It has already been given a class 2A recommendation, and OCT has been clubbed with IVUS in terms of its use. And to conclude, I will say that good imaging modality is a hinge on which the correct decision making is based. Not much experience is required to interpret the images of OCT. We do need some randomized controlled trials before we move ahead, and there are some happening in the segment of OCT, and I think we are in for thrilling times. Thank you for your patient hearing.
Thank you very much for that exhaustive talk, sir. It was excellent.
Thank you, ma'am. Thank you, ma'am.
Sir, when you say it is class 2A recommendation, you mean to say that it's for all patients?
No, it is class 2A for left main disease, but that is with ACCHA. ACCHA is still 2B with left main, but Europeans are generally generous, so they mention it for all segments actually. Where OCT, because OCT is not kept for left main at all, because there are problems with OCT in the left main segment. The problems are mainly with the ostial plaque estimation. They can't assess the plaque burden, and OCT is very well suited for distal left main disease. So it's primarily being used for distal left main this thing. So it clearly says that selected patients to optimize the stent results, you know.
So when you say actual size, what is it compared with, sir? OCT?
So there are certain phantom models which they use for sizing, and the sizing initially when the trials came with OCT, the sizing was based on the lumen. So they would measure the lumen and then size the vessel, whereas IVUS conventionally has been using media. So it has been seen in studies that IVUS results in kind of oversizing. So in iLumen 3, they revised the criteria, and in iLumen 3, they used the external elastic lamina for sizing the stents. So as you know, you have to have a distal reference and a proximal reference in any given lesion when you measure the length. So when you reach the distal segment, a distal segment is considered worthy of measurement for the distal reference only if the plaque burden is less than 50% there. There are no thin cap fibroatheroma or fibrocalcific plaques, or if this segment, you are able to make out 180 degrees of intima, media, and adventitia. So when you can make out these three layers, you consider this as the proper landing zone, and you can measure the reference segment here. So you can use, if you see all the three layers, you can measure from external elastic lamina to external elastic lamina, or you measure the lumen diameter. If you measure the lumen diameter, you add 0.25 and round it off to the nearest size of the stent which is available. Say if I measure in a given vessel, I get 3.25 lumen, I'll choose a 3.5 stent. And if I measure that stent is, I mean the lumen is 2.75, I'll round it off to the nearest, which is 3. Whereas if I'm using external elastic lamina and measure whatever, I will round it off to the closest that. So if I measure 2.9, I'll bring it down to 2.75 and post dilate. Or maybe in bigger vessels like LAD, if I get 2.9, I'll make it 3 also. So external elastic lamina comes closest to the vessels, and these phantom models implies that these are from the animal studies where they had actually done the sizing after doing dissections. So they use both IVUS, OCT, and then they compared the sizing of the vessel.
It is safe procedure, right, sir?
Yes. Yes.
Any questions, sir? Dimpu.
Hello.
Yes.
Hello. Sir, good evening, sir. This is Dimpo here, sir. So I had two doubts. Sir, actually, as we know, the CLOPCI was actually a retrospective study which looked at the outcomes, procedural outcomes, and two main things which stood the test of time was the various PCI optimization parameters, like the presence of a distal stent dissection or an MSA being less than 4.5 specifically, had even in the CLA OPCI late study also showed that it was going to predict poor outcomes when we use the OCT parameters. So now, why is it that when it was looked at it in a randomized way in Illumin 3, optimized PCI, I know it was not powered for that, sir, but then why is it that actually there was no difference between IVUS or OCT or angiogram when they looked at 12-year outcomes, 12-month outcomes, which was recently also published in Neuro Intervention, that they said that it failed to meet its outcome in the terms of reduction of MACE. My doubt was if the fact that we saw in CL-OPCI study that the stent length was significantly more in the OCT arm than the angiogram arm alone, and the number of stents which were used and the overlapping segments which were used, the overlapping parts which were used for obvious reasons were much more in the OCT arm as compared to the angio arm in CL-OPCI study. Could that have had contributed to the outcomes being not superior as compared to angio alone when it was looked at in a randomized way? So what is your comment?
Wonderful. That was a pretty long comment come question. So I'll tell you certain hard facts. CL-OPCI, there was a randomized arm and there was also a registry. There were two things which were happening parallel. And what came out of that was, it was, as you rightly pointed out, it was a retrospective. So there are certain limitations of a retrospective study, whereas Illumin 3 was a very well-designed study. Illumin 3 primarily was designed to compare the IVUS and OCT in terms of sizing and outcomes. So the outcomes, for outcomes, you need a little longer follow-up. For outcomes, you need a little larger number of patients. Otherwise, you will not get to see the outcomes. But all in all, from all these trials, which are still, they are not complete, the message is very clear. They say if your MSA is less than 4.5 millimeters square, that means your stent is underexpanded. If you've got distal dissection, these are subsets which are not going to do well, and these are the subsets which are going to have the need for repeat revascularization. These are subsets which might have events. This is in nutshell the information which is available from different trial data. Now, I have not specifically gone into each of the trials and I have not gone into details because I thought it is not required for you all at this point of time. But all you need to know is, number one, hard fact, that MSA less than 4.5 millimeter squares, presence of distal dissection. Malappositions have not been shown, even though I put across Illumin 1 data where they picked up a few malappositions. So malapposition has not been shown in any of the trials as of now to be a predictor of poor outcomes. Stent under expansion, dissections, these have emerged as two major things which predict adverse outcomes. More or less, the other trials have established kind of equivalence with IVUS and superiority over angiogram of OCT. But the RCT data where OCT is concerned is less, and we need to, plan more studies. We need more randomized controlled trials for OCT. But it is just piggybanking on the IVUS data, which has clearly established its superiority. Whenever you use an imaging modality, you will certainly find almost all the studies showing you that you will end up using longer stents. You will end up using a larger diameter stent. This is what Illumin 1 also showed, that they had to use longer and larger stents, even though in certain percentages they had to use shorter, but that is the general thing which has been seen. And the stent diameters, if you do an IVUS based study analysis will be certainly larger. Correct? So equivalence of OCT with IVUS has been established. Superiority over angiogram has been established, but the RCT data is still, not very rich where OCT is concerned.
Sure, sir. Thank you, sir.
Okay.
Sir, also the lipid-rich plaque, I wanted to just double confirm with you, sir. In your initial slides, you had mentioned it as a high backscatter, whereas I always remembered it as a low backscatter. So just wanted clarification on that.
No. So the high backscatter is on the surface. So lipid-rich plaque will always have a high backscatter on the surface, but it will have, so there are two things which we look at. We look at the scatter and attenuation. Correct.
Okay.
So
yes,
scatter is what happens on the surface. So all the lipid-rich plaques will have high backscatter. That means they will reflect the light back. But you will not be able to see anything beyond that. So there will be high attenuation. So that is why they are diffuse. They have very diffuse edges. You will not be able to see anything beyond that. So there will be high backscatter with diffuse edges. So that edges are not seen. Vis-a-vis this, you have a calcified plaque which will have very sharp edges because the light is now able to show you what is beyond the plaque also. So you can measure. So compared to IVUS in OCT, you will be able to measure the calcified plaque thickness. Whereas in IVUS, the sound waves will be reflected from the surface. You will not be able to go beyond that. It's like a rock. The sound waves will hit it and will come back. So you'll just see a one linear thing which will tell you, okay, there is calcium. Whether the calcium is superficial, deep, what is the thickness of calcium, IVUS will not tell you. But OCT will tell you everything. OCT will tell you, okay, this calcium is 500 microns in thickness. It has got this length. Okay, IVUS will also tell you length. But the location vis-a-vis the vessel wall, whether it is superficial, deep, and whether it is, what thickness it is, only OCT will tell you. Similarly, you will have again a high backscatter from the red thrombus. On the surface, you'll have high backscatter, but after that, the light will attenuate. It's like putting a torch in a viscous fluid is what is a lipid plaque, infrared light. So you will not be able to let the light will not go through. Similarly, putting a light in a blood column, the light will not go through, It is just that the thrombus has got a superficial layer of some fibrin deposits and platelets, etc. So it reflects back. Fine.
Understood, sir. Thank you, sir.
So the limitations are that you need to remember LV dysfunction, renal dysfunction, osteal lesions, and of course, in Indian setting, it's also the cost. It is an expensive modality. The cost is coming down, but it's still about, I think, the cost of the catheter is 25% higher than that of the IVUS catheter. So, but reusability is considerable if you maintain the catheter well. So if you really
how many times you can reuse, sir?
Madam, if Mr. Mohan is preparing, then you can use it 10 times. So it depends on the experience of your assistant. If he cleans it well and, after the procedure, the most important thing is that you need to clean it with the contrast has to be flushed out, and you have to clean it with the tap water and not the normal saline. Because what happens is when you clean it normal saline, it crystallizes. The salt in it crystallizes in the lumen, and at times the lumen goes bad. So we've used it quite a few times, but in Command Hospital, we would get catheters easily. So we have not really experimented as to how many times we can use it, but it is, I've heard people using it for 8-10 times, one catheter. For 8-10 cases they've used. So reusability is pretty good. It's a sturdy catheter.
Because we need to use dye, you said it is.
So, ma'am, I have certain case examples. So this is I have multiple talks addressing different segments. So I thought these are budding cardiologists. I should keep it at the base level. So I have case examples where I've finished, angioplasty of left main in 40 ml of contrast. So what you do is that you position everything, wire and this thing. Instead of taking a normal angio run, you take OCT images. Because when you take OCT images, you inject contrast. So I have basically seen the angiogram first, and then I wired the vessel, I parked the OCT cathode and acquired an image, which I need. I need when I start any angioplasty, I need an image in different segments. So on the with 7-8 ml of contrast, now I get an image on the OCT console by which I'll be able to calculate everything which I need to know for the stenting. So I get to know the side branch, main branch diameters, I get to know the lesion length, I get to know the lesion morphology. Thereafter, I just go ahead and do things the way I had decided to do, and then keep giving small puffs there, and then take a final OCT shoot, which will tell you whether you have malapposition or you have any dissections or plaque prolapse, or whether your stent is well opposed or not. So one view of OCT at the cost of say 10 ml or 12 ml of contrast will save at least 40-50 ml of contrast, because we then check things in, for sizing, we check in cranial, caudal and lateral and different views. So you obviate all that. You get one view which will tell you everything. What is the lesion length and where you have to park the stent. And if you have angiocore registration, that means you will acquire the OCT image along with your angiogram. Then you can see on the screen as to where your this thing, and you can landmark, okay, there is a diagonal which is coming out, and just after the diagonal is the area where my stent can be parked distally. So different ways you can correlate and save contrast. So it is a way of saving contrast also. But it is just that it takes a little while to get used to these things.
Okay. Any more questions?
Sir, I have one small question.
Yeah.
When we are doing an OCT in an ACS situation, or when when there is a dissection or a thrombus, how safe are we in injecting contrast at a high pressure when it comes to the dissection further progressing down or the thrombus migrating?
So, Varun, I showed a couple of case examples of ACS, and the most important thing to remember in ACS is that if it's a thrombus-laden lesion, a big vessel which is completely thrombotic, or if it's if on the other side, if it's a lesion which has got bare minimum thrombus and the wire goes through and the flow is established, and you are pretty sure of the sizes, please don't do OCT in such patients. I absolutely don't recommend OCT for all patients of ACS. I recommend OCT only if there is a diagnostic dilemma, or if there is a doubt, or you need 1 or 2 images for academic purposes or for teaching. ACS, you must remember, if the patient it's a kind of medical emergency, the patient has come with some amount of LV dysfunction, and the biggest enemy in this situation is contrast. The more contrast you give, the more load will come onto the LV. And, I have said this ad nauseum, that we have a very bad habit of checking our primary angioplasty results in different views. And thereafter, we feel happy, satisfied that we've done a fantastic job. We shift the patient to CCU, and within an hour, the nursing staff will call you that patient has gone into pulmonary edema. You've done a good job, but you've just opened an epicardial vessel. You have absolutely forgotten about the microvasculature, which is still stunned and closed. You've just opened an epicardial conduit, which will take the normal lytics in. There is chances of ischemic injury and reperfusion injury, so which will cause the microvasculature not to behave. So I mean, you don't want to compound it by giving too much of contrast. So I always advocate that in ACS milieu. I don't very strongly recommend OCT at all. What we've been doing is that with the ACS patients, if we've gone ahead and finished the procedure fast, and we've saved this patient, and we noticed that the case example where I showed you, the LAD was completely obstructed. We opened the LAD, but we noticed that he's got a left main disease. So we said, okay, we'll get him back. Let him come back to a normal hemodynamic state. After 3 or 4 days, the same patient is brought, and then the OCT has been done. We've done a study in Command Hospital where we've done about 55 patients who have been brought back for optimization. Because there were doubts about the stent implantation, and we are in the process of writing this paper. It has got very good findings and very interesting findings, and a lot of deficiencies were corrected when you optimize these stents. If you have large thrombus burden, you implanted a stent, the more post dilatation you do, the more you will send showers of thrombus into the distal bed and cause more stunning of the myocardium. So the ACS is a different ball game altogether. Now, coming to your question, the propagation of dissection with angiographic shoots is not a very common thing, can happen, but it generally happens when your guiding catheter is close to a ruptured plaque. It happens when your guiding catheter is not coaxial. Then if you inject, then you can cause. But if your guiding catheter is coaxial and is away from the lesion, and if there is a dissection there, you don't propagate. When you do CTOs, you create a lot of dissections. These are dissections which have been created for the purpose of crossing the lesion. All these dissections don't propagate very much because, yes, we use contrast in a controlled fashion. They don't propagate because essentially these are fibrotic or fibrocalcific lesions, and the vessel, the dissection will not propagate. Normally, dissections propagate only if the media, adventitia, they are all normal. And if there is a normal vessel and you create a dissection and you give a forceful injection, then the dissection will propagate and cause a formation of intramural hematoma. Or that is why we see spontaneous dissections in patients who have no atherosclerotic disease. In such patients, the dissections will propagate or increase on contrast injection. But most important things are you have to be close to the dissection, you have to be having a normal vessel, otherwise there will be arrest, because now you reach an area where the intima, media, adventitia are fused together and there is a calcium chunk sitting there. It will not let your dissection propagate any further.
Yes, sir. Thank you, sir. Thank you so much.
Thank you. You gave me an opportunity to speak about ACS. I must thank you. Madam, what do you feel about ACS? What I said, do you agree, or you have some other thoughts on acute, primary PCI?
You are better.
Wonderful.
You don't have much experience, no?
Okay.
So anybody else, any more questions? Arun? Should we close?
Yep, I think so, if there are no questions, ma'am.
Okay, Arun?
Yes, ma'am. I think no more questions.
Okay. Thank you very much, sir.
Thank you
so much, sir.
Thank you. Thank you very much, everyone, for being patient listeners. And I really enjoyed delivering these talks.
Yeah. We
Wonderful.
may ask you again after a few months, sir.
Yeah, absolutely. It'll be a pleasure, ma'am. It'll be a pleasure.
Okay.
It'll be a pleasure.
Okay.
Right,
Okay.
ma'am. Thank you, ma'am.
Thank you, sir.
Thank you,
so much,
everyone.
sir.
Thank you.
Thank you,
Thank
sir.
you, everyone. Thank you.